So thanks, Fabio, for nice introduction. And good afternoon, everybody from Dhaka, Bangladesh. And here, my mentor, my teacher, Professor Sanjoy is here. And participants from our institute, doctors and nurses, and from different institutes of Bangladesh, as well as from from other countries, we have seen Ethiopia and from Pakistan. Welcome you all to this presentation. My topic is respiratory support and safe oxygen use. So, let us share the breathing basics. Normal newborn breathing is abdominal breathing, and normal respiratory rate in newborn is 50 breaths per minute. And what are the signs of respiratory distress? So these are tachypnea, if respiratory is more than 60 per minute, retraction, grunting, nasal flaring, cyanosis, and apnea. And cyanosis and apnea are advanced stage of respiratory distress. When we find a baby have cyanosis and apnea, we shouldn't wait for tachypnea and retraction and grunting to diagnose it as a case of respiratory distress. Because if we consider this as respiratory distress, then it will be more advanced in respiratory distress. So baby can deteriorate more. And counting respiratory rate accordingly and recognizing severe chest injury are two signs that are often missed. I repeat. So if you want to count respiratory rate to decide that whether tachypnea or not, we have to count it for total 60 seconds in a calm child. If a baby cries, and if a baby is not coming quiet, and if we don't count for total 60 seconds, then it will give a misinformation. And sort of this chest indrawing is present in case of newborn, especially in the preterm newborn. So to consider it as a respiratory distress, we have to think about severe chest indrawing. And how to assess severity of the respiratory distress? It's a well-practiced as respiratory scoring system. There are two types of scoring. One is down scoring for term babies, and another is silver scoring for preterm babies. As we are talking about preterm babies, we will consider and give emphasis on silver scoring. So, what is silver scoring? The silver scoring evaluates 5 parameters of work of breathing and assess score. The total score is 10. For 5 parameters, score is 1. And more of the score is severe the respiratory distress in the newborn. So let's share the parameters: upper chest movement, lower chest retraction, J4 retraction, nares dilatation, and expiratory curve. So let me share a video to assess respiratory distress.
Dr. Sanjoy, there's no sound. You can just share the sound, Sabrina, or go on the share and you choose share sound if you want to share the sound.
So let me share the RDS pathology. So surfactant is a well-known liquid and it prevents alveolar collapse and expiration, that is, when expiration ends. And this surfactant start production in the fetal life at 24 weeks. And it producing the adequate amount not until 32 weeks. So if a baby born before 32 weeks, this baby will be surfactant deficient. And what happens if the baby born without surfactant, that is, if the baby born before 32 weeks, the tissue surrounding the air sacs in the lung that sticks together after escalation and causing the alveoli to collapse. So what surfactant does? Surfactant allow alveoli to keep open, and it is being shown in the images. And what CPAP is doing? CPAP produces positive pressure, and it predominantly helps by preventing collapse of the alveoli. And it also recruits more alveoli. And recruitment of more alveoli means more exchange of gases. And it does it by maintaining functional residual capacity. And CPAP keeps alveoli open, and it has another function. So it preserves functional residual capacity as well as it preserves surfactant. So let us see a video. So this is a video. It showed that initially there was collapse, and by providing positive airway pressure, the collapsing tendency was improved, and lungs are more inflated and more liquid from the alveoli. So how to manage it with RDS with CPAP? So you have to initiate the respiratory support, you have to monitor the respiratory support, and you have to know when to change support, when to OL, how to prevent and how to detect early the complications and troubleshooting. So it's a recent guideline. We all know, just it's for refreshing others. And in WSC 2022 guidelines, it shows the recommends a continuous positive airway pressure therapy is recommended in preterm infants with clinical signs of respiratory distress syndrome. 1. 2. Continuous positive airway pressure therapy may be considered immediately after birth for very preterm infants with or without respiratory distress. So recommendation one is preterm baby having respiratory distress, CPAP is recommended. And recommendation 2 is if the baby born less than 32 weeks of gestation, whether the baby have respiratory distress or not, baby should be put under CPAP. And recommendation 3, CPAP should be commenced as soon as respiratory distress is recognized. So I like to put emphasis on these informations. So nowadays, WHO doesn't recommend headbox that we are using very frequently. They better recommend CPAP in a preterm newborn having respiratory distress, and the preterm newborn less than 30 gestation to put on the CPAP without respiratory distress to recruit more alveoli. Because if we make delay in recruiting alveoli, and it will become much difficult to recruit more alveoli if we give or put under the babies under CPAP, and if we miss the golden time to prevent alveolar collapse and to allow or to recruit more alveoli. So these are not recommended for, that is, headbox and oxygen cannula just after birth. little bit of baby having respiratory distress. So let us elaborate this information. See the baby born preterm, if the baby is 32 weeks, baby is having respiratory distress or not, you should have to start CPAP with pressure 5 and if you titrate oxygen 21 to 30. And to observe whether the saturation is or poor respiratory distress improvement. And we have to increase pressure progressively up to 7 to 8 and then titrate FiO2. And if baby maintains saturation and there is respiratory distress improvement, we have to follow the baby closely and to monitor SpO2 to avoid hyperoxia and to avoid complications. And if the baby is more than 32 weeks, and if the baby has respiratory distress, and we have to start CPAP, and if the baby doesn't have respiratory distress, we have to start regular institutional follow-up. Again, we are giving emphasis. This is given a strike form less than 32 weeks of gestation to consider prophylactic CPAP. And before increasing parameters, we should have to ensure whether the machine is correctly functioning, whether interface is correctly functioning, to check whether any leaks, obstruction, or water in the circuit. So to monitor a baby under CPAP, we need skilled staff, we need quality equipment as well as quality consumable. How to monitor a baby? We should have to monitor continuously the vitals, that is temperature, respiratory rate, heart rate, and SpO2. We have to check circulation, that is cardiovascular status, by capillary refill time, by checking blood pressure and urinary output. We should have to check the severity of the respiratory distress by Silverman score that we have already discussed, and have to check the abdominal guard whether it's normal or increasing, to check whether that is CPAP value. And we have to consider about the neurological status and also to see the complications of machine as well as due to the disease. So equipment-related complications are nasal injury, gastric distension, what we call CPAP belly, and disease-related complications are pneumothorax, poor venous return. And regarding lab and image monitoring, this is not mandatory, but if we have the facility of doing blood gas, and it is to be done once or twice during the acute stage, and later when the baby clinically today, we can check ABG. And for chest X-ray, after putting the baby under CPAP, and if there is clinical deprivation, we can do chest X-ray. And we should be watchful whether there is pneumothorax. It's a common complication of RDS due to high CPAP pressure. So let us share the parts of Diamedica. It's a well-known machine. The participant here in each institute to a unit. So let me share the parts. On the left side, there is respiratory limb, there is oxygen flow meter, expirator limb, bottle dialer, CPAP level, hour meter. And on the right side, there is airflow meter, main gas outlet, and humidifier bottle. So this is on the x-axis, you can see the airflow meter. In the y-axis, you can see oxygen flow meter. And if we say, for example, if we like to give 4 liter air and 4 liter oxygen, then the resultant effort will be 58%. And this is the CPAP interface, like nasal mask, nasal cannula, and nasal bronchus. And after fitting it, you can see it is inspiratory limb, this one expiratory limb, and soft silicone cut nasal bronchus. And let us share a video of Diamedica.
Dr. Professor Sanjoy, we cannot hear the video. Just need to share the sound.
Sanjoy, just please check that why that we cannot hear any particular audio in all the video. Over.
You can go, when you go on share content, you have the option to include sound or not to include sound. You can just slide to the side to include sound.
Actually, in a limit, highest limit of our sound, it is 100%.
Yes,
It's in the share. It's in the share button. We still can't hear you. I can share the video if you want. Would you like me to share it?
Please share this video only.
Yeah. Okay. Can you hear it? Can you see?
We can see, but hear it.
You cannot hear?
Okay,
No.
let's-
Maybe
Let's start.
Mm.
The Diamedica Baby CPAP is a unique design providing high flows of oxygen and air from atmosphere using a modified oxygen concentrator.
We can't see the
Up to
video.
8 litres per minute
Flavia.
of oxygen and 8 litres of air are controlled by
Perfect.
CPAP is a unique design providing high flows of oxygen and air from atmosphere using a modified oxygen concentrator. Up to 8 litres per minute of oxygen and 8 litres of air are controlled by separate flow meters, allowing a variable gas mixture to the patient containing oxygen from 21% to 95% calculated by this chart. The gas mixture is humidified by this bottle before being delivered to the patient through silicone nasal cannula. The CPAP pressure is controlled by a bubble device on the side of the concentrator. Position the concentrator so that it is at least 30 centimeters away from walls or curtains, so that the inlet opening at the back is not obstructed. Plug the power cord into the mains electricity supply and turn on the concentrator. A yellow light should turn on and remain lit for a few minutes, usually within 10 minutes until the concentration of the gas supplied reaches and exceeds 85%. The yellow light should then turn off after this time, showing that the concentrator is running correctly. Fill the bottles to the level indicated with boiled water that has been allowed to cool and screw the lids back on. Connect the inspiratory limb of the circuit to the main gas outlet. Connect the expiratory limb of the circuit to the bottle. Dial up the level of CPAP required. Start at 7 centimeters of water. Fit the bonnet to the child. Fit the Velcro strip to the bonnet. Fit the appropriate size nasal prongs to the 2 flexible tubes. Place the prongs into the patient's nostrils and secure with the Velcro clips. When it is all in place, connect the inspiratory and expiratory tubes. Use the chin strap to help secure the equipment. Dial the flows of air and oxygen required to see a constant stream of bubbles in the water. Start with 5 litres per minute of oxygen and 5 litres per minute of air. Check and record the flows dialed and the oxygen concentration this provides. A total flow of 10 litres a minute is sufficient in most cases to deliver CPAP, which you can see by the continuous bubbling in the bottle. Check the child for signs of respiratory distress. Check the level of oxygen saturation and check if there are bubbles in the bottle. If the level of oxygen saturation is below 90%, or the child has severe respiratory distress, first increase the CPAP level to 8 or 10 centimeters of water, and then, if no response, increase in the oxygen flow meter to as much as 8 litres a minute. If there are still no continuous bubbles, check the nasal prongs are attached properly and reposition them so they fit snugly inside the nostrils. If there are still no continuous bubbles, check for leaks along the circuit and adjust the oxygen or air flows according to the chart in the manual. Refer to the Protocol for Use manual for further information.
Okay. So how to record CPAP pressure? So we have to check the 2 tubing, that is inspiratory and expiratory limb. The expiratory limb is underwater in of CPAP. And how to record oxygen and air flow? Note the flow in liter per minute and reach the center of the ball to bend down the level of the flow meter to avoid the paralysis effect. And we can see the images And to document the respiratory support in Diamedica, that is already shown in the video, the oxygen airflow, and to determine the CPAP pressure. And to record the saturation from the pulse oximeter, if we can continuous monitor this standard, and countries like Bangladesh and other countries and different centers in a country, and when pulse oximeter number is not that much available for each babies, we can allow intermittent monitoring. And for pulse oximeter check, to apply pulse oximeter probe in the hands, wrist or foot, and before reading the SpO2, we need to ensure that waveform is shown in the display, in the monitor, as well as to check heart rate manually to confirm that the heart rate showing in the monitor is equal what I am checking manually. And to clean the probe between babies. And when to wait. So readiness is determined when there is no respiratory distress and SpO2 blood gases are normal. So two patterns of weaning. One is abrupt weaning. It is done for the term babies usually, and if a baby gets oxygen less than 3 days, and sequential weaning for the babies who are getting more respiratory support for more days, that is more than 7 days. And in these cases, there is intermediate weaning is recommended, that is 1 hour off in 24 hours, then gradually 2 hours, 4 hours, 6 hours, 8 hours, and so on. And it's usually recommended for beta babies. And we have to check the complications of CPAP to pulmonary air leaks to see whether decreased cardiac output, to see impedance of pulmonary blood flow, to see whether any gastric irritation that we have already discussed, and of course, to see the nasal irritation, damage to the nasal septum, skin damage, and necrosis from fixing the devices. And how to prevent the complications? So to check if the mask fits well. A leaky mask can be dry out the nose and it can lead to necrosis. And we have to put an NG tube or orogastric tube to decompress the stomach and also for feeding, to check the nasal skin integrity for regularity of the skins. So this is the X-ray as you have mentioned. So the typical X-ray findings is a bilateral symmetrical granular opacities, as well as we can see the air bronchogram. And CPAP is safe in the babies with RDS in facilities without chest X-ray. So chest X-ray is not mandatory. We have mentioned earlier. We can put the baby under CPAP, and proper monitoring if the baby is under CPAP is much important than doing a chest X-ray. So this is the X-ray to show the air leak. You can see the collapsed lung and the air in the pleural spaces that we call pneumothorax, the right-sided pneumothorax. So what the take-home message is, the CPAP saves preterm lives. It reduces preterm mortality. And is it risky? Yes, risk of using CPAP, or the risk of morbidities. If done properly, CPAP is completely safe. And of course, inhaled oxygen is unsafe for the. Inhaled oxygen does not treat RDS, and excess oxygen is toxic, we know, because there is complications in the eye, there is complications in the brain, as well as there is complication in the lung as well, if oxygen overuse or excess use. And CPAP also reduces referral. And when the babies are under CPAP, we need to monitor the babies. If we need oxygen with CPAP, aim to keep the SpO2 from 90 to 94%. And we keep the alarm limit. Lower limit is 85 and upper limit is 95. Because excess use can cause oxygen toxicity. Lower use also cause some sort of complications. So we should be careful about monitoring the baby, especially oxygen saturation, if the baby under CPAP. And of course, you have to follow up the baby to see the complications on a regular basis. So before ending my session, I promised WC Collaboration Center for Newborn Saints, Bangladesh Neonatal Medical University, Neonatology Department, and for the Bangladesh Foundation. And thank you very much for questions. Now I need to hand over the mic to Flavia, the coordinator of this session. Thank you very much for questions.
Thank you. Thank you so much for this beautiful presentation. So we have 58 people in the room, and we'll be inviting you now to join our quiz that I'm sharing the screen. If you have questions while people are joining for Professor Sanjoy, you can raise your hand. And meanwhile, please join the quiz that we are going to go through a few scenarios and a few interesting situations. And just signal if you have issues joining.
I'd like to request participants to go to the Google and to go to www.menti.com and to enter the code. It's okay, Flavia?
Yes, can you see the screen with the QR code and the code?
Yes, we
Yes.
can.
Yeah, good.
No, Assalamu alaikum. No, we can't see the screen. I can't see the screen.
You can see the screen.
Smartphone. So www.menti.com.
But
Okay, I'm going to type in the chat the website
yeah, please type it so that we can join it.
and the code. And there is someone office user. I don't know who would be that, but if you have a question, please go ahead.
So,
Hello.
this is Dr. Liton Chandra Shah from Bangladesh. Yeah, I have a question regarding the humidification. How does the humidification and the temperature is maintained in this device?
Can you please repeat your question, Dr. Litton? Humidification. Temperature in humidified air.
Yeah.
Okay, for
How
humidification.
does
Yes, thank you for the question. So humidification is most important because in the air, if it is not humidified, it can dry out the mucosas in the respiratory tract. That can lead to infection. So, and also if the air is not humidified, it can lead to hypothermia. So for humidification, the recommended temperature is the body temperature. So we can keep 35, 36. Any more question?
No, my question is regarding these instrument, PPAP device. How does there is no temperature level in this instrument, PPAP machine? The WHO recommended CPAP machine. There is no temperature of humidification is there. So how does it maintain?
Sanjoy, let me just make it clear. Dr. Liton has a question that the Diamedica that is supplied by WHO, there is no, record temperature system which is here in that humidifier. So how would you actually ensure the temperature of humidification?
Okay. Can Flavia respond in this question?
Yes. Well, it's a very good question. Definitely, it's an automatic humidifier, so it's controlled automatically by the machine. I am not sure if you can control. Actually, you cannot control the humidification. It's not like other humidifiers that you also have, like for example, Fisher and Paykel, that you can see the temperature that changes according to the temperature of the patient and of the environment. It's fixed, but the exact temperature, I don't have this. It's a very good question. So I'm going to ask the America so
Yeah.
they can reply to us.
If I may, Flavia, let me come in. Hi, I'm
Yes,
Suman.
please.
We totally agree that the humidification in Diamedica is not the best. We should accept that. The reason why Diamedica has been provided is because Diamedica does not need compressed gas. And we find that compressed gas availability is an issue in many centers, and therefore Diamedica is used. If you, in your center, you have compressed gas and you have some other CPAP which does humidification much more accurately, please go ahead with it. This humidification is not the best. We have to accept it, but it provides some humidification. Yeah.
Yesterday I visited.
Just a supplementation to Suman Rao. It's a kind of a trade-off.
Yeah.
The Diamedica gives some other advantage where the resource-limited countries do not have all those things which Diamedica can provide at the cost of some degree of, not improvised humidification temperature. So that's a trade-off. I think that we have to understand. Thank you.
Any more question?
Yeah.
Okay.
Okay, good. So anyway, I would definitely, I don't know if Suman, if you know exactly what's the temperature, but otherwise I can check it and I come back to you if you leave your email in the chat.
Yeah.
So I can come back to you with the answer.
I think that would be good.
Yeah, perfect. Okay, so let's go. We have several people connected already. So you know how it goes. I will start. If anyone is still trying to connect. No? Okay, let's go.
Can anybody respond if they're connected or not, or facing any difficulties, so that we could understand? And can anybody raise so that we'll know that they're being connected?
Sorry?
Yeah.
Oh, Flavia,
They're
we don't.
showing indication by a thumbs
not-
up, etc. So you can make out
I'm not
they are connected.
I'm not connected. I'm Shireen from Pakistan. Not
Yes.
connected.
Would you like to connect?
Yeah, I would like to connect to the quiz you said, but it's not coming on my screen. I can't connect to the quiz.
Yeah, you can see on the
Need your-
chat.
You need your
have the
phone, Shireen.
website.
Here is the website. I can't see it.
It's
Is it-
it's written in the chat.
In the chat,
If
just
you
a
want.
minute. Let me see.
Yeah.
It's in the group or where? I can't see in the chat. Just a
You
minute.
can see the chat.
Yeah.
It's menti.com, the website. I can join the website. Okay. Well, it's fine if you cannot join the website. You can follow the questions. If you can
Yes,
see my screen, yeah. If you can see my
yeah.
screen, yeah,
Yeah,
you can.
I can follow the questions if it's available.
Yeah. So the questions are in the screen, and I've also say them. So you can also follow the questions and write in the chat if you want to write the answer. Okay. Okay, let's go.
Flavia, just tell them to
Yes.
enter the code, Flavia. Many of them are saying they are unable to join the website. They probably have gone to the website, but they've not put the code. So just remind them about that. Thank you.
So the code is here. It's 89116587. I don't know if you can see it. The code is being displayed. I'm also going to write again.
We can see that.
89116587. Can you just copy from the chat? And when you enter the website, you will see the place where you can put the code, and then you are in. Okay. We have 14 people, 15, one more. So let's go.
Please start, Fabian.
So yeah, let's go. So this is a quiz and it's a competition. So you don't need to, it's going to ask you to put your name. You don't have to put your real name. It will suggest you a name and you can just choose a pseudonym. Okay.
I think some of our residents, you please go to the Google and type the mentis.com and then use a code. You can join easily. Practice.
Okay, so let's share. Oops. I'm going to share the video that you have already seen again, and then there is a question.
There's no sound.
In this video, the newborn has an audible grunt giving a score of 2. Nasal flaring is visible from a distance, giving a score of 2. There is seesaw upper chest movement, giving a score of 2. There are some xiphoid recessions, giving a score of 1, and some lower chest recessions, giving a score of 1. So the total Silverman-Anderson score in this infant is 8.
So waiting for you to come. Okay, let's go to the question. You have seen this baby. So the question is, what's the best practice for this baby? Look at your device and you're going to have the options and you can just click. Inhale O2, support 2 liters per minute. Inhale O2 support 5 liters per minute, or put him on CPAP support PEEP5 to start. So what would be the best practice for this baby in the image that you just saw? Great. So we have 11 people that answered correctly, one that answered O2. So definitely this was a preterm neonatal respiratory distress, and the best practice for him would be to put him on CPAP. Would you like to add something, Dr. Sanjoy?
Let me check
Professor
something.
Sanjoy.
We have given emphasis, Dr. Suman Rao is also here, Professor Sanjoy is here. We have given emphasis upon giving the reference of WHO 2022 guidelines. So they have mentioned if the baby is premature, if the baby is respiratory distress, baby should be put under CPAP immediately after birth without having a trial of or oxygen support shoulder cannula, so that we can recruit more regularly to prevent collapse. Thank you very much.
Thank you.
There is a response put on mechanical ventilator. Would you want to comment on that?
Professor Sanjoy, would you like to comment on, there is a response on put on mechanical ventilator? I don't know if it's talking about invasive or non-invasive ventilation, but. Yeah. So if, as Professor Sanjoy just said, so the indication for this baby would first try CPAP and not oxygen, and also not as a first intention mechanical ventilation. So we start with CPAP as a first intention. There is one hand, Dr.
Abdul Manan.
Manan.
Thank you very much. When the score is 8, there is some recommendation to put the baby in mechanical ventilator. Over.
Thank you very much. So, if the respiratory score is recommended to put the baby under CPAP, if the score is more than 4, and there are also some recommendation if the respiratory score is more than 7 to put the baby under mechanical ventilator. So we are considering this There are the many places where mechanical ventilator is not available. So in that case, we can put the baby under CPAP. And to putting the question, our vision or objective is that to make people more oriented to use CPAP rather to use oxygen through headbox or to use oxygen through nasal cannula. Dr. Suman Rao and Professor, would you like to contribute some? Why?
Yeah, I would say in this way, if we want to make it generalizable, then the WHO recommendation is okay, where in this scenario of 8 out of 10 silver one score, the baby should be on CPAP rather than all the oxygen business. The question is anything above 7 of mechanical ventilator, which is only available in few higher centers. And the unit policy, if the unit policy is there, they can do that. But for making it generalizable, we have to say, yes, anything above 4 should be on CPAP. Is that clear? Over.
Dr. Suman, please.
Yeah, I would just like to reiterate what Professor Shahidullah said. In fact, the focus on mechanical ventilation for a preterm has shifted to CPAP over the last 2 decades. And we would like to give CPAP early at the first sign of respiratory distress so that you don't even reach a Silverman-Anderson score of 8. In this era, we don't want to reach a Silverman-Anderson score of 8 for a baby. By this time, the baby should be on CPAP. And second, even now with this kind of scenario in my unit where we do have mechanical ventilation, we still give a trial of CPAP because many of these small babies do well with the CPAP. And sometimes, of course, in such places, we have surfactant. So we try to manage non-invasively as much as possible. And only if a baby fails CPAP, then we go on to mechanical ventilation. So the focus, message I would like to give for all our viewers today is start CPAP early so that the baby doesn't have, at the first sign of respiratory distress. And that is the standard recommendation for all preterms with any respiratory distress. Thank you.
So,
Dr.
Suman,
Linton.
your message, let me. So, your message is that if you start CPAP at the earliest sign of respiratory distress, suppose a baby level of respiratory distress, any sort of respiratory distress per our definition, if you start CPAP, then this silver score might not go up to that 8 level of life.
Definitely.
So our recommendation, what Suman is working for a couple of years with WHO. So the recommendation is a preterm baby having respiratory distress. If we define respiratory distress, if we start CPAP in the earliest possible time, so that the silver score will not go up. And even if the silver score is 8, it's better to start with CPAP and to observe. If they will deteriorate, then we can go for ventilator. Thank you very much. Dr. Little.
Exactly,
Yes.
exactly.
Okay, next question. I have 17 people. Okay. So you have a scenario, you can look in your phone. 30-week preterm baby is presenting with respiratory distress just after birth. Baby's heart rate is 158, temperature is 37, respiratory rate is 72, chest withdrawing is present, capillary refill time is 2 seconds, noisy breathing is present. What are the signs of respiratory distress in this scenario? So you have these options: tachypnea, chest withdrawing, grunting, all of these. Good. So we have 8 people who answered correctly. The baby had tachypnea, chest withdrawing, and grunting, which was expressed as the noisy breathing. So congratulations. I don't know if there is any comments on that. This is more simple.
So Flavia, it was not written as severe chest withdrawing. Probably that make our participant a bit confused. Suman, can you make any comments?
Not really. I'm also trying to participate in this. It's quite a challenge because you need two
It's
devices
fast.
and then you have to see all of these. Yeah, but here in this, I think let us just say that respiratory distress is the focus. We are not really bothered whether it's severe or not. If you find distress, think of CPAP, even the
Yes.
earliest sign of distress. And as we know, the recommendation less than 32 weeks, that even without signs of distress, you can consider CPAP so that these babies do not get into distress and problems. So I would not really worry about severe or not. My goal is respiratory distress, CPAP.
Okay. Shadru sir?
Yeah, absolutely. I go with the opinion.
There
Thank you.
is another question. Then why do you do scoring?
Scoring for Silverman and others. So not everybody does scoring. And I'm not sure it's in the WHO guidelines either. So maybe someone can answer that. But it's not something that's done also everywhere. It's not a consensus. It's a practice for some centers. As someone was saying, respiratory distress signs are the most important. So if you have signs of respiratory distress, it means that the baby needs support.
Yeah, so scoring is a little bit objective way of doing it. For us, treatment of CPAP doesn't depend on scoring. But scoring is something I think a lot of us from the early generation are used to when CPAP was not the norm. So I totally agree with whoever has asked this question that in the current scenario, to initiate CPAP, to initiate treatment, you don't need scoring. But we still find some use of scoring in monitoring a baby who is already put on CPAP to see whether we need to, how to escalate care. Do we need to change the CPAP settings? Because it will tell you about how the baby is progressing. Is the respiratory distress settling down? So to continue to monitor a baby's scoring is still useful.
Just one, yeah, I mean, I agree. And a small supplementation. When the baby has got signs of respiratory distress, we put the baby on CPAP. At the same time, you still have a scoring system because escalation or de-escalation may
Okay.
be guided by the scoring improvement or going down.
Very
That's
good.
the point. Yeah.
Yes, sir, exactly.
Well, I agree with that. That's very objective. In my unit, we don't use the scoring, just for information. So we really use more the way that we describe the signs. It's a way of scoring also, but it's more descriptive. So let's go ahead. It's not. Okay, it will start. So if you remember this baby, you put this baby on CPAP because he had respiratory distress. His vitals are stable. He's on an FiO2 of 35%, and his saturation is 100%. So what's the next step for this baby? You stop CPAP, you reduce FiO2 progressively, or you switch to head box. Okay, that's good. So most of people answered you reduce FiO2 progressively to be between 1994, and this was the good answer. So this message here was we want to avoid hyperoxia. So it's very good that you put a baby on CPAP. He had some oxygen, you stabilize the baby. It's a premature baby, oxygen in excess, hyperoxia is toxic. So we don't want babies that are on oxygen with saturation of 100%. So it's good to reduce the FiO2 progressively to be between range. Just as a reminder, if the baby is on saturation of 100% and he has an FiO2 of 21%, you could just keep him on CPAP. It would be fine if he still needs CPAP or if you have any sign of respiratory distress. So the 100% is for when you are on oxygen, not on air. If there is any question or any comment. Yes,
No
I have a
comment.
hand.
No
Dr.
hand.
Manan.
Yeah, I think for any time We should not allow this saturation to hit up to 100%. That's because we don't know the 100% means what about the blood oxygen level in the blood. So this is my comments over.
Anytime when you are on oxygen, definitely. If you have oxygen support, you shouldn't be having a saturation of 100%, because actually when you hit 100%, your PaO2, it goes up exponentially, and then you have a higher amount of oxygen in the blood that is not related to the saturation, because the maximum that you can measure is 100%. But when you are in air, your PaO2, it stabilizes, actually cannot be toxic. So when you are exposed just to 21%, which is air oxygen concentration, it's perfectly safe.
Dr.
Yes,
Linton?
there is just one hand again.
Yes.
Office user.
Dr. Linton.
Yeah,
Yeah.
my issue, sometimes we found in the lowest FiO2, like 21, in that case also you can found sometimes the SpO2 is 100%. So what to do at that time? Over.
So that's good. If you still have signs of respiratory distress, the baby keeps on CPAP. This is good. The baby stable, keep the baby on CPAP. You don't need to put him on oxygen, or you don't need to stop CPAP. You will stop CPAP based on clinical signs of respiratory distress, not on FiO2 or on saturation. Good? Okay. We go to the next one. Okay, video. So you see this baby is a 32-weeker. It's his first day of life. He's on oxygen 100%, 2 liters. His saturation is 92% and his heart rate is 158. What's the best practice for this baby concerning the respiratory support? Let's get ready to answer. So increase oxygen flow, he's already in 2 liters. You can say that the baby is stable, so just follow up and monitor, or you start CPAP. Great, congratulations. So we have 14, the large majority that chose the right answer, which would be start CPAP. This baby was put, though there was a problem already with this, because the baby was already put in oxygen at first. So he should have been put in CPAP straight away. So as we see, oxygen doesn't treat RDS. And then the best practice for him would be putting him in CPAP, and then you can titrate oxygen if there is a need. But the best practice would be definitely having him on positive pressure. Is there any comment?
Javier, this is Dr. Sanjoy. So we have seen 5%, they have made comment like baby is stable, just monitor. And if you observe, we have discussed about the WC recommendation. So we have mentioned that baby is having respiratory distress, so should have to put the baby under CPAP. So here we can see there is one issue is that baby is getting oxygen through the cannula. And on the top of that, baby is having respiratory distress in terms of serious chest pain. So in that case, definitely should put the baby under CPAP. Over.
Can I just add something, Flavia?
Yes, please.
After all this kind of a presentation and one question previously, perhaps I didn't expect that 5 would say stable, just monitor. I didn't expect 1 would say that increase oxygen, because the whole understanding up until now that a premature baby having respiratory distress needs to be put on CPAP. So this time, after all these questions, I expected all would be, 20 out of 20 would say that the baby should be on CPAP. Over.
Totally agree with you, sir. Even it was little bit disheartening to see that 6 have said something other than CPAP, and therefore I think our hard work towards making CPAP more acceptable should continue. We still have to do our work. Yeah. Thank you for highlighting it. Back to you, Flavia.
Thank you. Well, thank you
Got
for the people who
hand up.
answered and the people who are participating. That's very good to have your answers and honest answers.
Dr.
And then
Manan?
the goal is to learn. So this is a way of learning. So let's go ahead. Dr. Manan, you still want to say something? Or it's an old hand?
No, I think it's.
Yeah, no. This is my new hand. So
The new hand.
my query and comments has already been made by my respected teacher, Professor Shudullah sir, and also supplemented by Suman Rao. So that is, I was also wondering, and also after the President Hot Professor Sanjoy has made very clear that premature baby, when there is respiratory distress, WHO recommendation is to put the baby in CPAP. So even then, out of 20, we have seen that 6 are given answer not to put in CPAP. So that was my question. So we have to be very sure, and also I think we have to we have to do more work on this subject and platform, that this message needs to be very clear that the premature baby respiratory distress need to put the baby in CPAP. Over.
So I think after the discussion, our participants will be encouraged and they may correct themselves, as because it's a long-term practice to give oxygen and to increase oxygen. So definitely this discussion will correct themselves, I think. Thank you very much.
Yes, I completely agree, Professor Sanjoy. Okay, let's go. We still have the chance to repair that. Okay, let's get ready. So this is a little bit longer. You have the question on your phone. So we have a 31-weeker that's on CPAP just after birth for severe respiratory distress. He's on PEEP of 5, 30% oxygen, and a flow of 5. At 2 hours, he's worsening, and he has tachypnea and chest withdrawing, and saturation is 92%. What do? You have this baby on CPAP, and then he's a little bit worse. He has more respiratory distress, and the saturation is too good. That's good. This question was kind of tricky. So we have 8 people who got the right answer. Check for complications and increased PEEP. And 6 people also got the right answer. It was just not the best answer, which was increased PEEP. So maybe it's still the 14 people that are scoring high. And then we had 2 people who said increased FiO2 on CPAP, which would not be the first choice here. Maybe I'll let Professor Sanjoy comment because it's his question. So please, Professor Sanjoy, go ahead.
Thank you. Because the font size is a bit smaller, probably it's difficult for me to put it out. So what is that is makes you respondent? Can you please help me? So this is the problem, the case scenario, and options. Under the yellow bar.
It's check for complications and increase PEEP.
Want to check for complication, and that is increase CPAP.
In the yellow, yes. The pink one is increase PEEP.
Increase PEEP.
The next one is increase FiO2 on the CPAP. And the last is stop CPAP and switch to inhaled
oxygen.
As we have already discussed, when the baby is put under CPAP, and this baby need to monitor whether baby is same as before, whether baby is retreating, whether baby is improving. So again, if we consider that the baby is deteriorating, we have to check whether any sort of complications or the circuit is properly functioning on board. We'll check everything. Only then we'll think of the changing the parameters, I think. So it responded well. So any comments from our other Professor Sanjoy?
Yeah, Flavia, can I just supplement Sanjay?
Please.
This is you said really, this is a tricky one, but if you understand, then you have understood the whole kind of respiratory distress and CPAP. Here, the baby is already on CPAP and there is deterioration. So no question of stop CPAP and switch to, so that doesn't come at all. Increased FiO2 and increased PEEP. Of the two, we all know that if we increase the PEEP, actually we can recruit more alveoli. First, we should try that rather than increasing the oxygen. Now, the choice between the third and the fourth one, increase PEEP versus check for complications and increase PEEP. This is important. Why? Because these deterioration could be due to many factors, including the complications, where if we just increase the PEEP, not addressing complications, we are not going to make the best. So therefore, addressing the complications and increasing the PEEP is the best choice. You get my point. I tried to make the difference between all the four options. I stop here.
Thank you, sir.
Thank you. So, okay, let's go to the last one. Thank you very much, Professor Shahidullah. Very important comment. So this is a long paragraph, so it's a long question. Now we have a 29-weeker preterm baby that's on CPAP just after birth for severe respiratory distress. The CPAP settings are PEEP 5, FiO2 30%, and flow of 5. On follow-up at 2 hours of age, the baby is found to be bluish. He has tachypnea that is increased and chest withdrawing that worst. His heart rate is 168 and he desaturates. Next 2 hours, the baby is required to increase CPAP pressure at 7 and FiO2 up to 60%. So you ensure that all the CPAP setting is good, that the baby is maintaining SpO2 persisting respiratory distress, and then in the evening, he deteriorates. So you have this baby that was getting worse and worse and worse, and then he gets even worse in the evening with severe respiratory distress, tachypnea, cyanosis, and low blood pressure and desaturations. And then you check his chest movement, and he seems to be decreased on the right sound, and the breath sounds are diminished in the same side. So the question is, oops. What may be the cause for the worsening of this baby?
I say one thing, everyone is going to be correct this time.
Long scenario, sir. Many thanks.
But everyone is going to make it correct, I am sure. I said so.
So limited that people will not be confused, I think, the options.
Do you want to comment, Professor Sanjoy, Professor Shahidullah? Please go ahead.
So
I think, Flavia, you read it so well. Everyone could understand. So credit goes to you more than anybody else. I will stop here.
So let me add something, sir. So if you see the first 2 hours, patient's problems, that is respiratory was increasing and chest injury was increasing, as well as there was tachypnea and spirit was decreasing. And what the resident did, he increased the FiO2 as well as CPAP pressure, it was increased up to 7. So we can increase pressure as well as FiO2. So we should keep in consideration that increased pressure may be at risk of developing pneumothorax, which is shown in the last part of the scenario. That is, baby having respiratory distress, and in one side chest is not moving. So, and also there is signs of hemodynamic derangement. So all this can be explained by tension pneumothorax. So our lesson is that we have shown it in our presentation to consider about pneumothorax, which is the common complications of CPAP, high CPAP. And we should have to practice to diagnose pneumothorax. Chest X-ray may not be available in some centers. We have to practice our what we call it is chest illumination to see whether there is air, so that we can diagnose it in the bedside. So over.
Thank you. I would like just to make one small comment on that. On the person that answered RDS normal evolution, because it may be not completely wrong. If you take into account that RDS is a disease that gets worse with time, and pneumothorax may be a complication of RDS itself. So just this baby, maybe it was because of CPAP pressure, or maybe it was because of RDS complication. RDS, in RDS, you have lungs that have a very low compliance, so they are very hard. And if the baby makes a lot of effort to breathe, he makes very high negative pressures in the lung, and this may cause pneumothorax. So this is a common complication for RDS with or without CPAP. So if this baby was in nasal prongs, in oxygen, maybe he would even have a pneumothorax before, or maybe he would have at the same time. So it's clear that this is also a complication of RDS. I don't know if anyone wants to comment on that.
No, Flavia, I think you made a very good explanation that pneumothorax is not only dependent on the higher pressure. It eventually, even an RDS baby, I would say that having a very high negative pressure, the alveoli may rupture and may cause pneumothorax. That you made very clear. Number two, here the other two very important striking feature is that one side of the chest was not moving and the breath sound was diminished. So considering these two and this, it comes out to be pneumothorax. But what Flavia wanted to say, it's not only, let's not look into the cause of pneumothorax. Rather, it is important to diagnose pneumothorax instantly to save the life of the baby. Over.
Yes, definitely. Thank you very much. Well, we arrived to the end, and let's see who's the winner. Nusrat. I don't know who, if you want to say something, I don't know who is the person, but congratulations, and congratulations to everybody that participated on the quiz. So this is the end. We are 20 minutes late. Thank you very much for all of this. Thank you so much, Professor Sanjoy, for all of your time and all of your patience and all of your sharing. And thank you, Professor Shahidul and all Bangladesh team. And Suman, would you like to say something?
Thanks, Flavia. I just wanted to thank Professor Sanjoy and more importantly, the entire Bangladesh team under the guidance of Professor Shahidullah, who's made this such a very rich seminar for us. This is one of the most important seminars because as part of antenatal corticosteroids implementation research, we are very, very keen to ensure that CPAP is used well and appropriately. And across all the sites, I know that we are struggling to make the transition from oxygen to CPAP. And that's the transition we would like to make very quickly when babies need, preterm babies need respiratory support. We would like to use CPAP appropriately with appropriate monitoring. And I thank Professor Sanjoy for putting so many case scenarios which emphasize these points and kept it very, very simple and Thank you very much, Professor Sanjoy. And most importantly, I think having Professor Shahidullah here with your expert comments means a lot, not only to Bangladeshi team, but to all the people across the antenatal corticosteroids implementation research family. Thank you very much. And it's been a pleasure to be part of this. Over to you, Flavia.
Thank you very much. Professor Sanjoy, would you like to say some closing words?
Sure. So I am feeling privileged to be present here and to have Shubham Rao, Flavia, and my mentor, Professor Shahidullah here. So there are three generations. Professor Shahidullah, the grand teacher, we're in the middle, and our residents as well. So it's a effort of, I think, about 7 days, more than 7 days. And we had a trial, I think Flavia was here, Professor Shahidullah sir was given some feedback. And yesterday we have a trial, and we were very happy that Shubham Rao had joined, having her busy schedule. And I'm also grateful to her. She have sent some videos. I requested her to send some videos about respiratory distress. And of course, I'd like to thank our Sabrina Tisha to work a lot, and our BSMMU team with the leadership of Professor Shahidullah worked a lot. And thank you very much. Flavia was in touch with us to make it happen. Thank you. Thank you.
Flavia, I just would like to acknowledge our other mentors whom I see in the group, Shireen, Gessit. I think I can't see all of them, but I know many of them have joined across the other nations. Thank you very much for making time for this. Means a lot to everyone to have your participation. Thank you.
Thank you. Thank you very much, everyone. We had 58 connections. That's amazing. And we will meet you again in 2 weeks for the next edition of the SSNC multi-country seminars with our Ethiopia team. And this will be available on recording. We are setting up a YouTube channel, so we'll be able to share with you all the videos. And we will also send the videos to your research teams. Thank you.
May I request everyone to put on their cameras, and maybe we could take one photograph of the large group?
That's a good idea. Meanwhile, Professor Sanjoy, you wanted to say something? You have your hand.
I raised my hand because our BSMMU team, as well as our colleagues, Professor M. Mannan, Dr. Smith is here. She is also joined into trial. And also our student is now a student professor, Dr. Parvez, he joined from now away from Dhaka, virtual session. So all contribution, all feedbacks make this presentation definitely spar your comments, a good one definitely. So I am also my gratitude to all of them to contribute. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you, Flavia. Thank you, everyone.
So Professor Shahidullah sir, can you make it before I leave?
What did you say?
You make some comments, sir, feedback or